Welcome to all. This is our first ICMLF conversation of 2025. And as is tradition, we do a wrap-up of the CML highlights of the annual ASH meeting. So we're recapping one of the major haematology meetings of 2024 in this first conversation. And again, while we settle in, I'll take the opportunity to remind you that later in the year, we have the 27th Annual John Goldman Conference, co-supported by the ICMLF and the European School of Haematology. So please mark your calendar for that later in October. So again, our first perspective of the highlights of ASH is the clinical highlights by Professor Timothy Hughes. Now, as many of you know, so Professor Hughes is the Precision Cancer Medicine Theme Clinical Director at SAHMRI, Cancer Professor at the University of Adelaide, and Consultant Haematologist at the Royal Adelaide Hospital here in Adelaide in Australia. He's the past Chairman of the International CML Foundation and the Fellow of the Australian Academy of Health and Medical Sciences, and also the Australian Academy of Science. He has been a principal investigator for many of the key clinical trials in CML and published over 300 papers with over 54,000 citations. So as I mentioned, Professor Hughes will share the clinical overview of the highlights of ASH. Professor Hughes, I'll hand over to you to share your screen and begin your presentation.
Okay, thanks a lot, Nicola. So yeah, ASH in San Diego 2024 was actually a great meeting. I think we're back to full strength again after the difficult years of COVID. San Francisco was looking its best, as you can see in my slide there, and the exhibition hall was quite amazing in some of the complexity of the models, etc. But I don't have a lot of time, so I want to focus on the key messages. Hang on, we go back one. Yeah, the key oral presentations. And if I have time at the end, I can mention a few of the posters. But these were the talks that were selected for their importance for clinical medicine in chronic myeloid leukemia. There were 6 that were presented, and I'll feature briefly each of these. So the first one came from our group, in the Australian group, led by David Yeung, who presented the data, an update of the ASCEND-CML study, which really was the first frontline study of Asciminib monotherapy, Asciminib being this fairly recently developed, though it's been around for 10 years now, allosteric inhibitor, so-called STAMP inhibitor, specifically targeting the myristoyl pocket of BCR-ABL. And this looks very complicated, but basically the study was taking all comers with chronic phase chronic myeloid leukemia at diagnosis with the standard transcripts, good performance status. Patients were started on, initially we started on 40 milligrams twice daily of Asciminib, which is the standard dose from the ASCEMBL study, but subsequently, we switched that across to 80 milligrams daily, a simpler dose, and there is evidence of its equivalence. So virtually everyone received that dose. There was some allowance for dose increase and some allowance to add on a ATP competitive TKI, but that's not the focus of this particular presentation. So this is really the key data that was presented by David, showing that in terms of achievement of major molecular response and a deep molecular response, in this case, MR 4.5, so less than 0.0032%, really deep response. That is the platform, if it can be maintained, for treatment-free remission. And you can see really quite encouraging numbers there, 78% achieving major molecular response by 12 months, 87% by 24 months. And looking now at 36-month data for MR 4.5, the majority of patients achieving MR 4.5. So really, I think quite exciting efficacy data. In terms of the adverse events, we've gone through these in some detail, and I'll show them in other studies as well. But one of the points of this slide is the fact that while there were adverse events in the first year and a few in the second year, there's very, very few coming through in year 3 and year 4. So this drug in the longer term is extremely well tolerated. We do see this significant incidence of lipase elevation. In most cases, that's not associated with pancreatitis and doesn't seem to have any great significance, but it seems to be present for all of the TKIs. But you'll note the sort of incidence there that we saw. One case of a cerebrovascular episode, a TIA, 2 episodes in the same patient. That's the only case of arterial occlusive events that we saw in the ASCEND study of 100 patients. But this is perhaps the negative data that we showed, and that is the fact that you do see development of mutations. The majority of these mutations were these myristoyl site mutations that were predicted to occur with Asciminib because it binds in the myristoyl pocket. It was predicted that resistance would possibly come from mutations within that pocket, and that was the case for most of these patients who developed mutations. But there were 3 patients, in fact, who developed the M244V mutation, one that we now recognize. It's a mutation that is also resistant to some of the ATP competitive drugs, but it certainly does lead to resistance to Asciminib. And we had just one case of a T315I mutation. What you'll also notice is that a lot of these patients actually got a very good response before they lost it. So a couple of patients there who actually were MR 4.5 out at 13 months and 24 months. And that's somewhat surprising. We very rarely have seen that in the past. Patients achieving a deep response generally, if they stay on drug, have very, very little risk of losing response. So that's a significant finding, and one that Sue may be exploring some more in her presentation. So moving on to the ASC4FIRST study. So this was now this is the randomized study that has received a lot of attention, basically comparing Asciminib frontline to the investigator-selected drug. And that could either be imatinib or a second-generation drug. And I think it's best to consider this study as probably 2 trials in one. The patients who were selected by the clinician for imatinib and were randomized either to imatinib or to the Asciminib, and the patients who were selected by the investigator for a second-generation drug and were then randomized to either Asciminib or the second-generation drug. I think they can be regarded as 2 separate studies, and I think that enhances our understanding of the comparison. So this is the data that I've rearranged to show that, and that is first of all looking at the number of patients who are ongoing on treatment, and look at the contrast between the patients on looking in the first 2 columns, the patients who were selected to receive imatinib, but either received imatinib or Asciminib. In that cohort, the discontinuation rate was 16.8% for the Asciminib group and 46% for the imatinib group. And likewise with the second-generation cohort, the patients who received Asciminib, 19% came off for various reasons versus 30.4% of those patients on a second-generation drug. What were the main drivers of that discontinuation? Well, you see treatment failure per ELN. For the imatinib cohort, the patients who received Asciminib, just 5.9% versus 18.6% if they actually received imatinib. And for the patients in the second-generation stratum, 4% for the patients who received Asciminib versus 8.8%. So in both cases, pretty clear advantage for Asciminib. Likewise, when you look at adverse events, patients in the imatinib stratum who received Asciminib, just 6% adverse events versus 13% for imatinib. And in the second-generation stratum, 6% for the Asciminib arm versus 13% for the second-generation arm. So clearly, both treatment failure and adverse events, clear advantage for Asciminib in both cases. And in terms of molecular response, you see here the comparison for all patients, but then the comparison in the imatinib stratum and then the comparison in the second-generation stratum. And for the first time, you're starting to see an advantage, not just comparing Asciminib to imatinib for achievement of major molecular response at week 96, but also Asciminib versus second-generation drugs at week 96. It wasn't evident at week 48, but now we see 72% versus 6.9%, and the confidence intervals don't cross zero. So that would suggest that we are achieving a greater number of patients achieving major molecular response on study when randomized to Asciminib compared to when randomized to a second-generation drug. We're also starting to see an advantage in terms of MR4. If you look at the imatinib stratum of 52% versus, or 53% versus 24%, and in the second-generation stratum, that's also a clear advantage for MR4, 45% versus 31.4%. Not yet an advantage in terms of MR4.5 in that particular, in the second-generation stratum, but that may come with longer follow-up, I suspect. But once again, we did see a significant number of mutations, remembering that there were 200 patients or thereabouts on Asciminib. So this was 10 patients, represents about 5% compared to around 8% in the ASCEND study. And in this study, we didn't see any cases of mutations that were outside the myristoyl site. So they're all myristoyl site mutations. And in some of those cases, there was loss of MMR, but not as frequently as we saw in the ASCEND study. And we also saw mutations with imatinib and with nilotinib, but not in the dasatinib arm, but the failure rate was similar across all arms. It's just that this is only looking at the patients who failed because of kinase domain mutations. So now looking at the adverse events in ASC4FIRST, we've already shown the figures for the adverse events leading to discontinuation shown in the middle. But here on the right-hand side, you see adverse events leading to adjustment, dose adjustment or interruption. You see the advantage of Asciminib compared to imatinib or the second-generation drugs. And importantly, looking at arterial occlusive events, it's around about 2% with the Asciminib and a similar number, or 2.9%, with the second-generation drugs. And as we've seen in most studies, very, very low rates. In fact, no patients on imatinib who had any arterial occlusive events. So it seems to be a similar rate to what we see with the second-generation drugs. So now moving along from first-line Asciminib to the first study that we have, really looking at a second-line cohort where patients have either developed resistance or intolerance to their first line of therapy and then were switched to Asciminib. This is part of the ASCEND-CML trial, which is a US trial, and it's going to include both patients in first line as well as patients in second line. The patients in first line are not yet included in the analysis, but we do have data now on the second line cohort. So these patients, as I said, either had a warning or failure on their first TKI, or they're intolerant to their first TKI and had BCR-ABL levels greater than 0.1%. And there was also allowance in this trial to have dose escalation, not a subtle dose escalation like we had in ASCEND, but a very substantial dose escalation from 80 up to 200 milligrams daily, and in some cases up to 200 milligrams twice daily. So I think that's going to be very interesting to see that whether patients who either lose response or don't achieve response can be salvaged by using much higher doses of Asciminib. So it's still very early in this study, but we have 71 patients that have been enrolled, and we have safety data on all 71. So far, out of the 71 patients, 67 are still going on treatment. We only have one patient come off for an adverse event, and a few other patients coming off for loss to follow-up, etc., but low numbers coming off study. But the median follow-up is still very, very short, just 18.7 weeks. And here we see the rates of molecular response, both patients being less than 1% on the left and major molecular response less than 0.1% on the right. And you can see quite encouraging results at this very, very early time point. So at week 24, we already have around 43% achieving major molecular response. And as you might expect, it very much depends on whether patients came onto the study because of intolerance or because of resistance. The patients who came on because of resistance, the rates of major molecular response were not quite as high, 31.3% at week 24. Patients who are intolerant to their first line have had very, very good achievement of major molecular response, 58.3%. So this is not surprising, but it is quite encouraging. In terms of adverse events, you can see here the grade 3, 4 shown in dark green, and the light green, the grade 1, 2. And similar to the ASC4FIRST, there were some patients with nausea and vomiting in the first 12 months of therapy, and patients with fatigue and headache. I'm not sure with with hypertension, how real that is. It has been reported, but it wasn't reported in the as a consistent rate in ASC4FIRST. So I'm not sure how significant that is. I think we need more data on that. So that's the other one to note. There is thrombocytopenia in patients on, in some cases, grade 3, 4. So that's all we know at the moment about ASC2ESCALATE. It looks very promising. I think in 12 months' time, we'll have a lot more data to talk about. Now, this was an interesting study from the French group led by Frank Nicolini, but he wasn't able to come to ASH, so Delphine Ray presented the data. And this is their TIPI, so-called TIPI study, trial of imatinib after ponatinib induction. And this is a very interesting concept where patients are given intensive therapy for 6 months with ponatinib. Now, we know that ponatinib is probably the most potent TKI that we have, but we're very much reluctant to use it frontline because of its toxicity, its vascular toxicity. But the idea here was to use it at somewhat modified dose of 30 milligrams a day, and just for the first 6 months to minimize that vascular toxicity. And then, having really achieved a dramatic response, hopefully, go on to a maintenance approach or a consolidation approach with the very safe and relatively well-tolerated drug imatinib. And then patients go on to a treatment-free remission phase later on. Now, because of the higher risk of ponatinib, the study design stipulated that only patients who had the ELTS risk score of intermediate or high were entered into the study. But after a period of initial trial running, it was found that ponatinib didn't seem to be causing excessive toxicity, so patients with low ELTS were allowed as well. But it did tend to skew the data towards patients with more high-risk ELTS, which you need to keep in mind when you see the results. And patients were not allowed to have any cardiovascular past history except controlled hypertension. So the primary objective was proportion of patients who were eligible for treatment-free remission after 36 months. So they had to have 2 years of MR4.5. So 170 patients, quite a big study. And you'll see the ELTS score of those patients on the right-hand side. So quite a high number with high ELTS score and even intermediate, and not many with low scores. And so the median follow-up is now 18 months. And interestingly, 89% of the patients were able to complete the 6 months on ponatinib, which I think is higher than I might have expected. And once they switched over to imatinib, 81.5 were able to maintain the imatinib over the period of 18 months. I guess some got intolerance and some needed to go on to other therapy. But so far, the event-free survival, an event in this case is a death from any cause, progression to blast crisis, permanent cessation because of adverse events, or study withdrawal. And you can see that it was at 92% after 6 months of ponatinib, and it's 86% now at 18 months. There was a sudden death in the first 6 months, probably cardiac, and I suspect that may be ponatinib driven. There was also one case of myeloblast crisis, but overall, it looks to be encouraging as an approach. In terms of the cumulative incidence of molecular response, you see there very good rates of major molecular response in MR4 at 6 months, and then somewhat plateauing after that once patients switch across to imatinib. And there's the cardiovascular events. But really, besides the sudden death in the first 6 months, nearly all of the events were hypertension, only one pulmonary embolus and one carotid stenosis. So there wasn't a lot of cardiovascular toxicity in this study. So now to move on briefly to mention TGRX678, which is another allosteric inhibitor or STAMP inhibitor. And this is the third one that we've heard about after hearing about Asciminib and sorry, I've gone blank on the second one now, Turns 701, which we didn't hear about at ASH. But TGRX678 looks like a very interesting allosteric inhibitor as well. And This is showing its specificity for BCR-ABL, and very interestingly, according to their data, it doesn't inhibit c-ABL, whereas all the data that I'm aware of would suggest that Asciminib does in fact target c-ABL as well as BCR-ABL. That may be an advantage in terms of the toxicity profile. But so far in the it's a classic sort of phase 1 study using a Bayesian logistic regression model for selecting doses. They're going through the paces with this drug, and it looks very promising. Rates of major molecular response you see in the bottom there, particularly good for patients who hadn't received any prior Asciminib, ponatinib, or Olverembatinib. But even for those patients, there was some level of response as well. So very early data, but it does look promising. We also had some data on Olverembatinib, which we've heard a lot about in the 3rd line and beyond. And now we have 2nd line data, which was presented at the meeting. And this was patients who were resistant to or intolerant to one TKI, but the vast majority were in fact resistant to one TKI. The dose now is established at 40 milligrams alternate day. And we now have the analysis of 43 patients where the vast majority were resistant to their prior therapy. Only a majority didn't have a mutation at the time that they started on their Olverembatinib. And here's the rates of molecular response or cytogenetic response, but a rate of MMR of 40.6% looks encouraging. Toxicity is what you might expect, the hematological toxicity, also this skin hyperpigmentation that we see with Olverembatinib, and also hyperuricemia. So my final slide, in the Asciminib data that we saw, frontline Asciminib studies confirm the superiority of Asciminib compared to imatinib and compared to 2nd-generation drugs in terms of molecular response. Quite impressive tolerability and safety. However, the kinase domain mutations do seem to be an issue that we need to understand better. Nearly all, but not all, were myristoyl site mutations. The 2nd-line Asciminib data looks very promising, but it's still quite early. Ponatinib as an intensive initial therapy is a really interesting concept, but I don't know how it would proceed now in the era of STAMP drugs. I'm not sure it will, but we can certainly discuss that. And then we have TGRX679, the 3rd STAMP inhibitor, which is showing promise, as well as further data on Olverembatinib in the 2nd-line setting. So it was a good, quite exciting ASH meeting for CML, and I'll now stop and hand back to Nicola. Thank you.
Thank you, Tim. Yes, there are lots of interesting data coming through